Sometimes I'm asked a question about my experience in hernia surgery. Um, I did my first hernia operation in 1987, so it's about 33 years back. And since then, I did a few thousand of open hernias and a few thousand of laparoscopic hernias. But I was very fortunate that I worked with some of the best surgeons in the United Kingdom to learn hernia from. First and foremost, I was working with Professor Robin Kennedy in Yeovil, Somerset, and he is a great anatomical surgeon. And the open hernia surgery under local anesthetic that I learned from him is amazing. So if I was to perform an open operation under local anesthetic, this will be a completely ouch-free operation. So the patient will not say even ouch once. Because lots of time you see surgeons performing the operation under hernia and the patient is jumping up and down and is being given sedatives and tied down. That's not the way to do open operation. So the principles that I learned from him were extremely helpful. While I was working in Somerset in Yeovil District Hospital, Liechtenstein repair came out as well, and where we had to use a mesh. And that was in mid-90s, 1995. And the reason for that was that Department of Health had done a study and they found out that the recurrence rate was unacceptably high after open hernia surgery. So they wanted to standardize the treatment, and rather than patients having various different type of operations, they standardized this to using a mesh. So the recurrence rate came down from 1 in 5, about 20%, to less than 1% after the introduction of the mesh repair. I became interested in laparoscopic hernia surgery in 1994 when I went to the meeting in Worcester, which was the inaugural meeting of Association of Laparoscopic Surgeons in Great Britain and Ireland, or this was called as Association of Endoscopic Surgeons at the time, AESGBI, rather than ALSGBI, what's the name. My boss, Professor Kennedy, convinced me that I must go and attend the meeting. This was the inaugural meeting. And I was most impressed because Professor Chris Royston from Hull, he presented a series of first 1,300 laparoscopic hernia operations with a recurrence rate of 0.13 only, which was impressive indeed. Great surgeon who had done lots of work and lots of service for the hernia patients in the United Kingdom and Europe. I brought a video back from, this was an old VHS video, big one. We had to use it in a VCR. Sat with one of my colleague registrars there who was doing locum there at the time, and we watched the video 3 times, and after that he asked me which side was it and I said to him maybe left side. So the laparoscopic approach is much more difficult than an open operation. You need to learn open operation. We study the anatomy of human body from front to back, not from back to front on the abdominal wall. So lots of surgeons who are very experienced in open repair find it difficult to adapt to laparoscopic or the keyhole operation. Anyhow, my interest remained, and I did 2 or 3 operations with one of my consultants, Mr. David Griffiths, in Yeovil District Hospital, and then I moved to my next job in the Royal Surrey County Hospital. I could never realize that that was the epicenter of hernia surgery in Europe. An amazing place headed by Professor Michael Bailey, who truly is a great surgeon, and he has really introduced the laparoscopic TEP approach in Great Britain, Europe, and especially in France, in Ercot. I was very fortunate to be his right-hand man for about 8 or 9 years. We ran many courses, taught on many courses. Our results were presented to NICE for approving the laparoscopic approach as the best approach for hernia repair. And in 1999, when our data was presented, probably out of 4,200, 1,850 operations were mine. This was a high volume center where we performed lots of operations, and we dealt with all sort of complex patients who might have had a recurrence 6 to 8 times. And we would do that laparoscopically. Our results were excellent. All our patients were followed up by our laparoscopic fellows, and we had a very robust data to talk about the efficacy of this technique. NICE recommended the laparoscopic approach for bilateral and recurrent hernias, but not for unilateral. Though in the committee meetings they had agreed the laparoscopic approach was better for unilateral, bilateral, and recurrent hernias. However, when inquired by my boss why they wouldn't recommend a unilateral hernia as to be best treated by laparoscopic approach, the response was that the cost will be unacceptably high for the government. However, ALSGBI, under the leadership of Professor Michael Bailey and other presidents, kept on providing letters to its members, surgeons who were trained in laparoscopic hernia operation, that unilateral approach was better than bilateral approach as well. And in their respective hospitals, they were able to carry on unilateral hernia operations laparoscopically. Then in 2002 and 3, we did a study in which was designed by Professor Michael Bailey to be presented to NICE, and we did 40 operations. In fact, I was the sole operator on that study. I did 20 laparoscopic and 20 open operations on these patients. And these were unilateral hernias in young patients who were office going, so that we could show and answer the claim that it didn't make any difference if the recovery was quicker after laparoscopic hernia, because most of the hernia patients are old and they don't go to their work. So we took 40 patients, 20 laparoscopically operated, 20 open, all office going, all had unilateral hernia. The total cost, the time of surgery, their postoperative pain, their recovery and everything was assessed and very carefully by a laparoscopic fellow there, who would be there in every case with me, who would draw about the approach for the patient in the morning. So these were completely randomized patients, and he would assess all the time. And the results were fascinating, because when I was performing the surgery, our team was very experienced and good, because as we used to do hundreds of these operations every month, we would work like a machine, and we were a very well-oiled machine in Royal Surrey County Hospital. We would do about 8 cases in a day on a day case list, and even a bilateral hernia in a 75, 80-year-old patient done at 4 o'clock, finished at 5, would go home at 6:30, and he would walk home comfortably after the operation. Our anesthetists were very good as well and provided excellent care to these patients. The operative pain relief and post-operative pain relief was excellent. So I think the team worked very well in that hospital. Our patient setup time was 1 minute 26 seconds for open operation, 1 minute 36 seconds for laparoscopic. So thereby meaning we have received the patient in theatre and we have started painting. From then on to knife to skin is the preparation time. So it was less than 1.5 minutes in both approaches. And that shows if you have a good team, you can be very efficient. Operative time was about 14.5 minutes for an open approach and about 14 minutes 40 seconds for a laparoscopic operation, skin to skin. So starting with the first cut and putting the last dressing onto the skin was about 14.5 minutes for each. I was reasonably experienced in both the approaches, and I had done high volumes in all my jobs, and I did lots of waiting list initiatives as well, doing these operations in bulk. So speed was good, but speed doesn't mean anything. You have to have a good operation, a bloodless operation, because slow is fast. If you try to rush and you get a complication, you'll be there for ages afterwards. So you have to do everything systematically, smoothly, and get an excellent surgery, an excellent outcome as well. And here, as outcomes were to be presented to NICE, any result would have gone there, any risk or complication. At one stage, my colleague who was doing the statistics and getting all the data, he requested me to slow down with the open operation. And I told him that I might be an enthusiast in laparoscopic surgery, but I had to run and do a fair study. And as I was experienced in both, I would do the right thing and do the operations at their full pace. The outcomes showed that the laparoscopic approach was better than open approach. This was presented to NICE, and in August 2004, they came up with their latest guidelines from the National Institute of Clinical Excellence, United Kingdom, and they agreed that laparoscopic approach was a preferred approach for unilateral, bilateral, and recurrent hernias, all type of hernias. So I'm very proud of my involvement at a very, very small scale in different places and contributing to the development of hernia, teaching and training of the hernia, on the courses in MATU, which we ran about 3 to 4 courses a year, attended, very well attended by at least 15 to 20 participants each course. And then I used to go and visit their centers. So I've traveled everywhere from London to north to Liverpool and further north, Ormskirk, various places. And I've been to Europe and other countries to teach and train in hernias and establish this technique. It's a beautiful operation if done appropriately and nicely. The outcomes are very good, patients are grateful, and the surgeon is very happy with the outcomes as well. I personally believe that there is room for improvement in this operation as well, with smaller cuts, and that's what I worked upon and I'm working with it. And that provides an additional advantage to the patients as well. So this operation is here to stay. This will certainly improve in its quality and efficacy for the patients. And by far, I'm very proud to be a small part in the overall scheme of the things in the United Kingdom and Europe, disseminating and promoting laparoscopic hernia approaches for groin hernia and other hernia techniques.